continuing education. So it's very little motivation.
Trying to click.
Okay. Whoop, it worked. All right. We're starting now? Okay. Very good. Hello. Welcome to launching a centralized medication financial assistance program, herding cats towards low-hanging fruit and other mixed metaphors. So for today, we have 4 total objectives: identifying a medication patient assistance program model for medium to large hospitals, organizing, developing, and integrating a team of specialists, challenge for the use of an EMR, in our case Epic, for support, and identifying a third-party software. But when I talked with Melissa, what she said was, no, your real objectives are you're speaking after lunch, so don't put everyone to sleep. Keep it as fun as possible, but offend as few people as possible, and embrace the suck. So this was actually a Bethism. Does everybody know embrace the suck? So embrace the suck, a verb, military slang, to accept or appreciate something that's extremely unpleasant but unavoidable for forward progress. First popularized in 2003 by Marines in Iraq. And our situation here can help us make the best of any situation, and collaboratively we can discuss to hear examples of what did not work perfectly and how can we make it better. A little bit about myself. I have the greatest gig in the world. I am the director of central pharmacy services at Scripps Health. What that means is I'm over a variety of groups, most of which have nothing to do with one another. We have a centralized compounding pharmacy that compounds about 2,400 sterile products a day for 5 hospital campuses. We have a resource float pool with pharmacists and technicians, a telepharmacy service, which are pharmacists that will do renal dosing, order verification for inpatient and outpatient, a centralized prior authorization team, and then most recently our medication patient assistance program team. A very long bio, but really what you should focus on is the last sentence, which is, besides a passion for healthcare, my great devotions are my family, naps and hammocks, good cheeseburgers, and bad puns. And one of these may come into play today. The hammock will be set up right over there. Okay. Oh, about Scripps. So for those of you that are not familiar, 5 hospital campuses, 32 outpatient centers. We have 3 walk-up retail pharmacy, 1 closed-door specialty pharmacy, more than 3,000 affiliated physicians, 16,000 employees, treat close to 750,000 patients annually. And a very interesting county that we're near the border to Mexico. We are a military town. We are a vacation spot, and so we see enormities of different payers, different insurances. Few definitions, so we're all on the same page. MPAP is going to be Medication Patient Assistance Program to help patients who lack drug or health coverage or are unable to afford medication, prior authorizations, a choice by insurance, or a healthcare system that a service or a medication is deemed medically needed. Few more really quick ones. One is to herd cats, for those of you that are unfamiliar, an attempt to coordinate or control subjects that are uncooperative, referring to extremely difficult or impossible tasks of leading other people towards a common goal, cats being independent animals that do what they want, when they want. Finally, low-hanging fruit, a thing or person easily won, obtained, or persuaded in business to focus on easily attainable goals. Also a key component of the manager speak corporate bingo card. Show of hands, who's familiar with manager speak corporate bingo cards? One? Only one? Here's the corporate speak company bingo card. In this case, we have low-hanging fruit. Look at that. That's almost like a preview. I don't have the bandwidth. Don't throw me under the bus. Per my last email. Get our ducks in a row. It's a no-brainer. We're going to be playing this later, and whoever wins bingo can have a thing of the grandmother's chocolate chip cookies they gave out at lunch. So what's the scope of our medication PAP team? Right now, it's self-administered drugs that can be filled at our retail pharmacies, our closed-door specialty pharmacy, but also any outside pharmacy. If it goes to an outside specialty pharmacy and the patient still needs financial assistance, we will help with that. Discharge medications for patients leaving any of our hospitals, we will help with that as well. Medical, we do help with medical, but it has to be for our infusion centers or our hospital-based outpatient infusions and clinics. We do some medication replacement but relatively low amount. I know some organizations do a lot of medication replacement. Right now, that has not been our focus, and generally considered out of scope as medication replacement within the hospital. And again, into our time machine, go way back to 2017. So October 2017, I was working quite happily in inpatient. I had been an inpatient guy for about 17 years. My boss came in one day and said, "We're doing a restructure. We want you to be the manager for a central prior authorization team." I said, "You are in the wrong office, Tony. I don't know anything about prior authorizations. I haven't worked retail in 15 years. You couldn't pick a worse person for the job." But he said, "So what? You're going to do it anyway." In January of 2018, we launched our central prior authorization team, medication central prior authorization team, dedicated pharmacist technicians with an original goal was to provide efficient, friendly, and professional service to all Scripps patients and employees. And a few months in, something really strange happened. We were getting requests for prior authorizations. When we looked, it was no auth required, or we had already gotten a prior authorization and it was coming back to us anyway. What I began to realize is prior authorization did not equal affordability for the patient. So for example, patients on an amazing new drug cost $10,000 a month. We fight like heck and get that prior auth approved, and they'll cover 80%. But strangely, at the end of that, the patient wasn't that stoked about having to pay $2,000 a month for their medication. So prior authorization not equaling affordability. Throughout this talk, there's going to be 3 of these kind of picture analogies. So hopefully you'll bear with me and even find them amusing or interesting. You have to look harder at the problem you're trying to solve versus the one you think you see. A while back, I was in a 99-cent store. I have 3 kids, a mortgage, a ton of pets. So I shop at the 99-cent store and I'm buying things for myself. And I came across this box of air freshener right by the checkout counter. Does anybody notice anything strange about the box of air freshener? Yeah. There is. Now, if you open this up and put it in your car and you love the smell of cod and shrimp you're in luck. If you're looking for cool scents instead of cod, you're picking the wrong thing. So what you think your goal is doesn't always equal where you're headed. Time Machine Part 2. 2019, I happened to be at Epic, which is the EMR we use. They have this big conference, the UGM, and they gave a couple of different healthcare organizations gave really interesting presentations on a financial assistance module that was launching in Epic. There was Houston Methodist and Aurora Healthcare. I put the class numbers in case anyone wants to look them up. And in my opinion, it was really neat, but it didn't apply to drugs at all. It was really about charitable and financial assistance for hospitalization and sometimes for things like outpatient surgeries and procedures. Also, Scripps would not agree to additional money to implement the module. But during the course of this discovery, I found my organization actually had 2 pharmacy technicians that were performing financial assistance for medications already. So I shook the apple cart. I talked to each of their managers. I talked them into letting me meet with them on a monthly basis, promising I wasn't trying to steal them away. And I did get permission to talk with Gemini and Stephanie. So Gemini and Stephanie, 2020, they were working in silos. In the case of Stephanie, she was working funded under a 340B program. She had spent 5 years at Scripps and many years before at a different institution, helping indigent patients, helping elderly patients, people on low fixed income. These patients were very high touch. In some cases, they didn't even have a home address to coordinate for what we consider relatively low cost medications. The other was Gemini. And Gemini, since 2014, had spent at least some time working on financial assistance. She was paid for under the oncology, and she did mostly oncology patients, very expensive, including off-label. Doctors at the forefront of prescribing, prescribed medications. Insurance companies don't want to pay for it yet because it's not on label, right? It's considered experimental in their opinion. And she would go out and try to get these drugs funded other ways. Quick pause. Am I going too fast, too slow? Just right? You doing okay? Okay, good. Okay, so working in silos. So neither of these 2 people had met each other, and they described vastly different MPAP programs. The delivery of medications, refills, notification, almost every aspect of what they did was different. Also, very manual process. If you walked in their offices, they would have big filing cabinets. They would have a stack of manila folders. These are the ones that are new. These are the ones that processed. These are the ones approved. So comparing those two as apple to oranges isn't even doing it justice. And I had these painful workflow meetings that no one should ever have to sit through. And these Visio workflow summaries, no one in their right mind would ever subject others to, especially in New Orleans on Wednesday afternoon, right about now. Okay, so this is Stephanie's, and I'm not going to go over all the details because I'll put you in a coma. But among this, the top part was actually her workflow for initial financial assistance requests. And what I was zeroed in on was noticing just how many different ways she would get these requests. They would phone call her, they would email her, they would Skype her. This is before Skype disappeared and turned into Teams. They would send in-basket messages through the EMR. They would fax her. It would come in a bunch of different ways from a bunch of different people. The overview of Gemini's, you can kind of see by the structure it's different. Again, if you want to sit through this, we can talk about it at the end, or at 3:30, we're doing a work group. We'd be happy to go over it, but kind of drilling down, same thing, looking at her process. It was not standard. It was very sporadic and lots of inputs. So I had this goal of having 4 people dedicated to just medication financial assistance, and I call them the Fab Four. And so for those of you that may remember, there used to be a music group in England. I think they were from Liverpool, right? Yeah, from Liverpool. And they were called the Beatles. This was a while back. If you don't know, you can ask your parents. But so officially, as of January 2022, all 4 of these individuals reported under me. And now the starting lineup for your Scripps MPAP program from oncology, we have Gemini. And then from 340B, we have Stephanie, but of course, embraced the suck. She got promoted. The week we launched our module, she was gone. So she became Jennifer. Got an FTE 1 expanded, and that was Tammy, who actually came over from Walgreens Alliance. And then Gabby, I stole from my other group, my prior auth team. So I went to my prior auth team. I said, you folks have done a great job. You're doing amazing. I'm going to take one of the people that does pharmacy benefits. I'm going to move her over, and full time, she instead is going to do financial assistance, and I'm not going to backfill her. So cue the angry mob with the torches. Cue the manager speak. Guys, we need to work smarter, not harder. Team, it's time to tighten our belt. Oh, smarter, not harder. Tighten our belts. Getting closer to that cookie. So the other question is, why dedication MPAP FTEs? A lot of times what you'll hear is folks have models where you have pharm techs or others that do financial assistance as a portion of their work. One of the classics I've heard is folks that have a specialty pharmacy, they'll work as technicians in the specialty pharmacy, and they'll do some financial assistance. Or there may be others, medical assistants, nursing, others in the clinic that again will split their time. In this case, I wanted to have them focus on that because we're not only looking at things that are filled at our pharmacy, but across the board, also across the entirety of a 32 clinic organization. So I wanted to get that economy of scale. If you tie your technicians that are doing financial assistance to your fills, then you may have a lot of hard time expanding, or you may even be pushed for contraction if your profit margin on those fills goes down, or if your number of scripts goes down. Also, the time windows. In some cases, financial assistance can become available, but for very limited amounts of time. So if you don't jump on it, it's gone. In the case of Gemini, her story was she was actually an IV technician. She did compounding for chemotherapy, pre-meds, supportive therapies in the clinic. And then when she had a little downtime, she started doing financial assistance. And we needed her to do it more and more. And eventually that became more or less her full-time job, with a tug of war of we need her to make the IVs. No, we need her to get the drugs covered. So a shared resource in this case didn't really work. We're going to move on to the second of my picture analogies, and hopefully you'll like this one as well. So oftentimes people talk about lean management, lean Six Sigma, do more with less, but it's not always a good choice. And here's why I want dedicated financial assistance and not folks that are shared model. So these are our 2 younger kids. There's 3 kids in all. This is Ruby and William. And these days, they're much older. Ruby's almost 13. William is 11. But this is when they were younger. We went to the park. It's a sunny, beautiful day, and still they were cold. So they borrowed Dad's jacket. In this case, we see pretty good coverage. Shared resource between 2, pretty good coverage. You can imagine this in your specialty pharmacy on a day where maybe it's not crazy busy, don't have as much going on. They definitely have time. Here are the same two sharing a pair of pajamas. One pair of pajamas shared between the two of them. As you can see, the coverage is not nearly as good. Mom is in the audience, so we are going to censor that. But yeah, so you can imagine this being a crazy day, super busy. You don't have that extra little bit of time to do financial assistance office. So the EMR we used was Epic and Getting Better All the Time. A long time ago, there was this group called the Beatles. They sang a song called Getting Better All the Time. At UGM 2019, as I said, interesting, not applicable to drugs in my opinion. Early in 2020, I found out Scripps Revenue Cycle had agreed to a discovery and funding for the module, but their target was the same as what I had seen at other systems: hospitalization inpatient and a little bit on procedures and surgeries. They did an updated demo, which had some potential. It talked about medications could be part of the module, not really built out, very limited. But RevCycle foolishly agreed to give me a seat at the table. So from then on, when they had their planning meetings, I got to be there, kind of like the kid that gets to join the adults at the Thanksgiving. March 2020, they announced there would be slight delays expected due to a new novel coronavirus. Long story short, it was about a year and a half before they picked it up. COVID was a little bit more of a blip than they expected. But for me, it was a great thing because by the time September 2021 rolled around, the demo for the Epic module updated was much better for medications with flag systems, med groupers, and even medication-specific fields. So Scripps decided to do a two-phase with phase 1 in November 21, phase 2 of May of this year. So this was their official announce. May the 2nd was when we were releasing the financial assistance module for medication. And this program did a lot of cool things. I am not here to plug Epic or other software that I'm going to talk about, but it did a lot of really neat things. So it provided a standard way to request financial assistance on a patient using an FYI flag. It directly fed to a work list that could be split up and shared among the Fab4. It allowed tracking tools in a dashboard and workbench and exportable reports, so no more manual spreadsheets of trying to log who you helped and how much monetary value was and when it needed to be renewed. Also permitted patients to self-request. They can go into My Chart on their phone or computer and request it. And to me, this was the single most important thing. Is I was like, I want it to be patient-based. Patient thinks they can't afford their medication. They should be able to directly ask, say, hey, I can't afford this, help me. I was so fixated that this was going to be the most important thing. So naturally, the biggest fail was in this department. And we'll get back to that soon. AMR storyboard with visibility, so you can look at every patient to show if they were approved, and standard work that the team could follow, and potential to generate automated reports for renewal seasons. So I'm going to do some screenshots. If this is not interesting to you, just let me know. We can go a little faster. If it is, I can talk a little slower on it. But so this is an example with an Epic of an FYI flag where they would drop down and select it. And then the flag type was financial assistance medication. And then they would use what's called a smart phrase, where it would fill in some basic fields for the person that wants to request that financial assistance. This would be what is seen by the end users in the clinic, could be any number of folks, a PSR, an MA, an RN, MD, what have you. Anybody would have access to do that. And then from there, it would drop into a work queue, as a patient work queue, and then that could be split up, and we could also run reports out of it. And then below are some of the details for the fields, and there's most of these were programmable, so if we wanted additional fields, we could ask for them. Document uploads, it allowed us to get away from paper and have uploads of W-2s, financial assistance applications, tax returns, hardship letters, and things of that nature as well. And these also could be crossed over to the patient portals. And then the dashboard, which my team doesn't love so much, but me as a mean old manager, I do love. You can look at turnaround times. You can see how many people are processing. You can get breakdowns by national federal poverty level, pardon me. And so it has a variety of things you can see as a very quick snapshot. Reporting, so you can do things as workbench reports. You also can have ones that will export to other reporting systems if you want to look at larger blocks of time. Again, I can speak on this more if there's specific questions at the end, but otherwise I was just going to show you an example of a few of them. And then this is something I do want to spend a little bit of time on. This is the My chart. We call it My Scripts. So in this case, someone went in with an Android phone. You could use an Apple phone or a desktop. And you would go under customer service and then ask for financial assistance. And so that was the initial name that we decided. If a patient wanted to say, hey, I can't afford my drug, you would say, ask medication financial assistance. What we found was we got a lot of messages. And none of them were about financial assistance. They would be, I am a patient on insulin and my blood sugar has been very high. What should I do? I'm a patient on oral chemotherapy and the pharmacy says I can't get a refill. What should I do? They were all manner from the simple to the extremely complicated, from the low impact to high impact for patients related to medications. They were seeing this and they didn't understand it was they were just reading ask medication and not any further. So we changed it to financial assistance for medication, leading with financial assistance, thinking then we wouldn't get these medication questions. Didn't make much of a difference. We still were getting medication questions. And finally, financial assistance in parentheses, medications, to further downplay the medication part. I think out of the last 45 messages, I think one or two were I think it was two. Two were actually related to financial assistance. So in the end, I ended up turning this feature off because what was happening was really important, timely medication-related issues were going to my financial assistance techs, waiting for them to see it, and then routed over to the doctor or the nurse pool. Chart review. So there's two different ways you can actually look at status. In this case, it's one that's under the chart review tab, and in the next one, it's under the storyboard. Of the two, I think storyboard is probably my favorite. It's just on the sidebar. And so you can click on it. You can get a real-time status. As soon as my techs update it, you can see it. So you can see, is it in process? Has it been approved? Drill down to the details. So this has been, I think, a really awesome thing. There's a lot of education, though. You're going to probably have to educate a lot of, depending on your healthcare organization, a lot of clinics, a lot of folks on how to look at it. Otherwise, they're just going to fall back on calling you or emailing you for updates. So we said we embraced the suck, and we did see problems, and more problems. The biggest issue, I said, was with patient-generated financial assistance. We went through 3 revisions and ultimately ended up ending that just because I could see it was more likely to lead to a negative patient outcome from a message not getting answered in a timely manner versus relatively few true patient-generated financial assistance requests. You need to help with unaffordable medication, but high costs are very relative. Case managers asking for help on medications that many people would consider low cost, but for the patients, they were not. Also, patients with very high aggregate household incomes still balking at the cost. Had a patient, she was really upset. She was getting an injection in the clinic for allergies. She had to get it every month, and her copay was up around $1,000. And she said, and it was a mandated white bag. Wasn't one that you could do under medical benefits. So she said, wow, this is really unbelievable. So we said, okay, we're going to try and get it for you. You have a commercial plan, so we're pretty sure we have a good chance because you're not a government pay. Well, it turned out their household aggregate income was over $1 million a year. So we weren't able to help them, despite my initial guess that we should be able to help. But so even for a family making an aggregate of $1 million a year, the idea of paying $12,000 a year for one single med was still shocking to them. And then growing pains, doing it for all the clinics and all the meds, seeing the volumes can go up. Maybe the dollars don't, because if you tend to focus on, in the case of oncology, a smaller group of meds, but ones that are very high cost, if you're measuring it in dollars, suddenly you're doing more, but your dollars aren't going up as much. Prioritization of what's important. Really interesting thing about people, they tend to think whatever they're doing is the most important. Oncology people, oncology is the most important. Cardiovascular, cardio is the most important. Dermatology, oddly, dermatology thinks dermatology is the most important. There's very few people that want to get online at the back of the line. My team still loves paper, manila folders, filing cabinets, manual faxes. It's been a constant struggle for me to get them off paper, especially people that have been doing financial assistance for 5 years or 10 years. And then the requesters, the people who liked email, they would just email Gemini or Stephanie, or they would just send an in-basket message. Hey, John Doe needs help getting with this meds. Boom, they're done. Well, now we have to go in, open an encounter, put on a flag, use the smart phrase. Doing all that's relatively quick, but it's longer than just sending an email saying, help John Doe. And then a paradigm shift. In some ways, we were sacrificing speed, but establishing a process and standardization. Paradigm shift. Paradigm shift. Who's getting bingo? We're getting close, guys. All right, third-party software system. So in my opinion, it is best practice to try and work with a third-party software system. There, I notice, are several on the list that were invited to this summit, so I'm not going to pick any favorites. We did review 4 offerings, and they had all pluses and minuses. They varied in cost, structure, functionality, and platforms. In the end, we did partner with Med Data Services, MDS, and if you have questions on that, I think we will have someone in the room that can help you with that. Right, Matt? Okay. And so our decision was really we were launching a new service. And so some of these systems were much more expensive with more bells and whistles, but we weren't really sure what we wanted our service definition to be as far as the third party. The other is some of them will offer real-time feeds in and out of your EMR, which sounds great, but you're going to have to get that through your IT governance. Does your IT governance allow you to do real-time feeds in or out of your EMR? Maybe they do, maybe they don't. And then the last is what's your staffing model? If you think your staff can only look at this once a day, then do you really need real-time or frequent send-outs? If it's once a day, then once a day upload is probably sufficient. Programs like these can help in locating available funding. They can help with auto-population of forms in some cases. Some will convert to e-fax and other transmission. But really, whichever one you choose, it can help you to proactively maximize assistance with goals of looking at opportunities. So they will be able to screen patients so you're not having to screen them all manually and say, these are the folks that are most likely to benefit from specific programs. We actually launched MDS in April, 1 month before we launched the Epic module, so the staff could get used to it. Initially, we were not using opportunity capture just because they had more than enough with the manual requests. More recently, we have started to do that, and so we're working on the best way to optimize that. But I think we did, it was 4 patients, right? We did 4 patients in the last 3 weeks, which is 4 is better than 0. But so this is a future area for growth for us. All right, this is going to be the last of my little picture analogies. So hopefully, what does success look like? So this is back from my days when I was in the hospital. This is Johnny. And Johnny, he works for facilities engineering. And I opened a ticket with Johnny. I said, Johnny, I need you to do 2 things. I need you to mount the phone on the wall at arm's level. I need you to mount a flip directory at eye level. And there he is, eye level. Arms level, arms level, eye level. That is success, huh? This is Amber. Amber is one of the ladies on my team. Is this phone at her arm level? No. Can you do this at eye level? No. So it's Christina. Christina is shorter than Amber, and she is also on my team. Is Christina the shortest person from that department? No. No, I had 2 ladies that were shorter than Christina. They were not available this day. But so I had to explain to Johnny that although you have closed my ticket, unfortunately, you did not meet my needs. So success is not always easy to define or easy to achieve. These were our metrics for fiscal year 2022, at least through July. From October to April, we did manual tracking on individual spreadsheets. I did have, it was before the team had formed, if it's before January, and I did have someone out on a medical leave as well. From May through July, it's Epic data pull. You can use Slicer Dicer, which is for those of you unfamiliar with Epic, it lets you manipulate data very quickly. Also, we can look at volumes of requests based on location, care line, and other customer metrics. And so in the future, instead of having these very rudimentary, like how many did we do, approximately how much money is it worth in free drug, approximately how much do we obtain in grant, although not the entirety of the grant dollars used. This is dollars obtained, not utilized. But in the future, we could have different metrics like turnaround time, approval rates, reason for denials, and those can feed into our key performance indicator. Bingo. All right, so are we there yet? 4 years ago, late 2018, I knew exactly what we needed at my organization. We need a dedicated team for MPAP, including expansion in FTEs. We need an EMR that integrates process so everyone can see it, everyone can use it, and it's totally transparent. Third-party software system to maximize efficiency. And I said it over and over and over again. I said it to my boss, to my boss's boss. I said it at meetings. I sounded like a parent saying, this is what we need. Our patients can't afford care. Please listen to me. But the worst possible thing happened. I got everything I asked for. They gave it all to me. I had to use duct tape and chewing gum, but I got it all. So are we there yet? And what I would say is, I'm not there yet. The journey for us has really just been started. We're making great progress. I think this hopefully in the minds of the people in the room is something, oh, I can learn from this, or maybe you're ahead of where I am, maybe you're at where I am. But this is kind of the discussion to this point. Not there, but a lot closer to there than I was 4 years ago. How early did I finish? You didn't hold it 15 minutes. An hour. Oh, goodness. Well, then let's do some questions. No questions? Yes, ma'am.
Great presentation.
Oh, thank you.
So the beginning of the process, you talk about, where does it start? Does it start at the time when prescription is created? Or are you doing any kind of system-wide distress screening for financial distress?
Yeah, that's a really good question. So the majority of ours are going to be based on somebody screaming uncle. So the majority is going to be based on the money. That is too much. In the case of the off-label from oncology, they knew going in, hey, we're picking a really new therapy, or we're picking something that doesn't have a lot of research behind it. So we'll submit it for prior auth. We'll try to submit 2 peer-reviewed journal articles, but some of those they know right up front it's either going to be a cash pay or write-off or financial assistance. Part of the reason to utilize, I think, programs, the third-party programs, is to try and discover, can you catch those patients in advance? Does that help?
It does. So Scripps hasn't launched any system-wide financial stress.
Correct. We don't currently have a process where we say, this is your estimated income, this is the estimated out-of-pocket for a drug, so we're going to pursue financial assistance proactively. That'd be a future goal. No, sorry. That was the point. The point of that last slide was, I am not done yet.
So our team, we have a team of 30 people who do patient assistance across 3 states.
Are you hiring? Can I go through?
So we have the distress screening in place for both inpatient and outpatient. We have a work queue that's built within Epic that when a patient is scheduled, it falls into our work queue. So we're double checking a lot of times.
Yeah.
And then something that we've implemented this year is when a patient comes into registration, they have a change of insurance or insurance is lapsed. We get notified real time because they could have fell in the work queue 2 weeks prior, didn't qualify for something. And we've been able to capture a lot of patients because unfortunately you have to have the accountability on the patient to say, hey, we have new insurance. And some patients don't realize that. They don't understand the prior authorization aspect of treatment.
So we do that on the prior auth side, but not on the financial assistance side. So in the case of anybody that's getting infusions or episode-based medications, if there's an insurance change or update, it automatically will trigger back to our work queue. So we absolutely do that for prior authorization, but I believe her question was on the financial assistance side, and we don't do that yet on the financial assistance side.
Yeah, we've captured a lot in that.
I love it. I'm going to come pick your brain. We should switch. You should be talking. Other questions? Yes, sir.
Good question. Is your process and thinking based, did Epic work around your process and thinking, or did your process and thinking work around it?
So the Epic module did have some tailorability, but a lot of it was not tailorable. For example, the FYI flag process was not my favorite. It was clunky. You had to open an encounter to utilize it, and that was something they could not alter. Most of the ones where it's a drop-down field where you can pick what foundations or how you want to define your funding or your or your type of assistance, you have a lot of ability to change those. So I would say probably we worked around Epic more than they worked around us. But it's not a dig on them. They have so many customers, I understand. They're like the Godzilla of EMRs. Is that okay? Yeah. Any other questions? Yes, ma'am.
For medications, other non-approved medications or experimental, how are you getting around finding programs for those? We struggle a lot with if it's denied for that reason, they're also not going to be covered with an assistance programs.
Yeah, so it depends. Some of them will, they'll want you to have financial assistance. Some of them, they want to have a denial or a denial plus an appeal or 2 denials. Some of them will not do coverage. I think a lot of them have been direct from pharma that we've gotten, and it's usually been for, like I said, clinic infusion, not self-administered. And if you'd like, I can connect with you a little later and give you some more concrete examples.
So it sounds like to me that currently it's a referral-based type of system rather than a proactive based. So let's do a scenario.
A scenario.
Yeah.
All right, Dan.
So you have a patient who's saying, I need
Yes.
and have Medicare. So you need to go for foundation assistance.
Yes.
And every once in a while, those foundations are closed. Right?
Just every once in a while. Yeah. Usually it's like an open wallet.
So foundation is closed. Patient is saying, I can't afford this. What's your next step? What do you guys do?
Yeah, I mean, you get on wait lists, right? You try to look at creative ways of finding funding. In some cases, there are, again, I really don't want to play favorites with third-party EMRs or anything else, and certainly not a specialty pharmacy, but some of the specialty pharmacies will have their own internal foundations or internal fundings. One of the things we've tried really hard is to see if we can create an internal foundation fund at Scripps Health for medications. At this point, we have not been able to. We're trying to figure out, can we fund it out of 340B based on the community benefit or other things? But yeah, so it tends to be wait lists. It tends to be looking at
When you say wait list, is it wait list with the foundations?
Yeah.
Okay.
Yeah.
All right. So your staff are tracking it. Like
Yes.
3 months ago, they needed assistance. Let's hope we can get them into one that's retroactive.
Yeah, that's a really good question. Actually, so you asked a question that I didn't realize you were asking. So one of the things you can do with a work queue is we added waitlist as a categorization. And so you can either close it out and then run a report to pull wait lists, or you can keep it as active and defer it. You can defer it for a month, 3 months, 3 weeks. And so by using it's like the same thing as what schedulers and prior auth does. By putting in a deferred work queue, you get it out of your clutter of active patients you're working on right now and can come back and kind of recheck on that. Now, it doesn't open any kind of magic funding, but it does kind of keep it on your watch list.
And does it stop the bill from going to the patient?
Yeah, so that'd be a billing hold. So that's kind of like, who do you know from your billing or your business office? And so there are times where you'll say, hey, we're working on this. Can you please place a hold on the bill, because the patient's not going to be able to afford it and they're just going to be upset. And usually they're really understanding because they know we're trying to help. But yeah, that's kind of like, who's those saying? Sort of like, well, there's still a lot of like, who do you know, reaching out to this person.
You mentioned that you do very little
Drug replacement. Yeah. So currently that's not been the crux of I know some organizations do a lot of that. And I know some of the folks that'll do consulting work will be like, there's so much money in drug replacement. It just hasn't, I'm sorry, go ahead.
No, there's not.
Well, it's one of the sales pitches, right? And again, I've had 2 different companies come by and give sales pitches where they basically say, we're going to save you millions of dollars, and then we're going to take this much of it. And when you start talking to them, usually there's a big drug replacement component, either outpatient infusion or hospital. The team's small and they're young, so it hasn't been what we've gone after. I'm really happy to consider that in the future, but we're also like, it's kind of like a toddler just starting to walk. We're a little early for running.
I think one of your slides, did I see it correctly? 29 million?
Yes. So that's a little bit monopoly money. I think I spoke to that just. So that would be if you were to do a cash pay for them. So it's $29 million, but no one in the world would pay $29 million. And it's the same thing with the grants. I wanted to say the way the grant money is tracked is that's grant money that you've gotten approval. The reality is almost no person stays on therapy, uses all that money during the course of the grant, right? So money is money, and it's important. We all know money's important, but those figures are I kind of like to call them monopoly money. They're not real hard dollars. But as you kind of being recorded, huh? I should watch what I say. As you're, expressing value of a group, you want to make sure that you don't undervalue your group to the organization.
So you are in California.
We are.
So access to insurance in California is very different than access to insurance in other states.
I will believe that to be true.
So is it truly self-pay, or is it off-label that you're focusing in on the free drug that you're currently doing?
Currently doing right now?
Right.
It's both. It's both. Actually, so what I was saying was back when Gemini was dedicated to doing oncology, she had more of the off-label. These days, that's a much smaller focus. And I think the other thing, I can't remember which of you said it, but the other thing is on the prior auth side, I think we've gotten better at either being able to get it or being able to message back to the prescriber, listen, I know you think this is amazing, but it's not going to get covered. So maybe consider something that's going to get covered. And some of that messaging is really hard, right? It's really hard, especially when your staff are not necessarily high-level clinicians that feel like they're having that peer-level discussion. Oh, Dan, you're giving me all the hard questions. I thought you said we were out of time.
Nope.
All right. Should I talk a little about Cover My Meds? We have Cover My Meds in the audience as well. So we have a representative from MDS and a representative from Cover My Meds. And so those happen to be two of the partners that we use. MDS, I said about the third party for financial assistance, Cover My Meds for our prior authorization. So we use their portal product, but predominantly we use an Epic integrated product. So if there's any questions on the prior auth side, originally I was like, hey, I could talk about the prior auth, and Beth and Melissa said, no, don't talk about the prior auth. They're here for financial assistance. There's like all these other talks on prior auth. Don't talk about prior auths. I guess
How does your organization find assistance for patients?
You mean what are some of the tools we use to find assistance for patients? So the text tended to go to needymeds.org. A lot of it's been, Pan Foundation, things like all the kind of regular tools there. I'm sorry. Fund Finder, yeah, all the kind of regular tools that folks like to use. A lot of it seems to be based on kind of people building up their own personal library. So the folks that do it for a while will get to know, like, these are all the portals, these are all the shortcuts. I really wish it wasn't tribal knowledge. So that's one of my long-term goals is how do you get this from being like a tribal knowledge to something a little more across the board?
That's the issue I've had right now.
I believe it. Let me know. I can give you my contact information and we can kind of share the information we have depending on where you work. Maybe it's transferable, maybe it's not. So which
Home infusion.
Home infusion? Yeah, home infusion is a little bit different beast.
Yeah.
But yeah, so I'm happy to share. I'm real open to that. And it's got my contact info, so just reach out and say, hey, I saw your boring talk, but I had another question. All right. Yes, ma'am.
You mentioned that your team also helps with outside specialty pharmacy.
Yes.
So how does that work? Because way we work right now, we bill medically
Mhm.
IV infusions.
Yes.
So whenever a patient has to use an outside specialty pharmacy, we're kind of taken out of it because that's kind of between the insurance and that specialty pharmacy for like copay assistance. So how are they able to help those patients?
Yeah, in the case of things that have to be filled at a specialty pharmacy, when we do the prior auth, we actually have a hold functionality. So it doesn't release to the filling pharmacy until after we've done the prior auth. And that way we're the point of contact for the providers, because otherwise the outside specialty pharmacies, if any of you are in the room, I don't mean to insult you, so don't take this the wrong way, but they'll be like, oh yeah, we do all the prior auths, we do all the financial assistance, but ultimately they don't have the chart. So then they got to reach out and go, hey, can you give us chart notes? Hey, can you give us this? Whereas my techs have access to all that information. So we already have the prior auth approved before it's ever released. And then if there's a financial assistance need and the patient says, hey, my copay was too much, then the clinic can just drop it into our queue and we'll actively go out and seek out financial assistance. If the specialty pharmacy decides they want to do it on their own, we won't slap their hand. They're welcome to it. But it's a service we offer. It's not a mandated service. But so part of what we do that kind of, because otherwise I think I hear part of what you're saying is you could be working on it simultaneously, right? Is it doesn't get to them until after we've already done a lot of the work.
Our problem too is because we bill it,
Yes.
dealing with the manufacturers, so we have to wait until after the patient gets refused,
Yeah.
give that explanation.
Yeah. The explanation benefits.
It's an easier way to help these patients with the outside specialty pharmacies. If the white bag is coming in, we'd like to be able to help those patients if we can.
Is it across the board, or is there a specific specialty pharmacy that you're seeing it with?
I mean, we've got a Credo, OptumRx. I mean, we see all the specialty.
Yeah. And when you list in the referrals as approved, are you indicating if it's a medication that's being white bagged?
They're supposed to do that because we have our own financial clearance team.
Got it.
They get the authorization, so
Yeah.
they are supposed to be filling out that paperwork and
Got it.
sending it to the pharmacy to let us know.
So maybe what I have is I have the advantage of being over the medication prior auth team and the medication financial assistance team. So I don't have the same disconnect just because they're both under me. So I can explain to you what we do, but if you're dependent on an outside department kind of doing their job, then that may be I don't want to guess at the problem, but that could be the problem. Or if you wanted to maybe set up some time with one of their leads, and you can book some time on my calendar and I can explain how we do it and see if that helps to convince them of the importance. The other thing you'll see is like sometimes it will be approved as a white bag outside and it comes in and they give it to the patient, they do all things supposed to, but then at the time of administration, they don't mark it as a patient-owned med or with a PSL modifier, I think is the term they use, so that it'll end up dropping a duplicative charge under medical as well. And that's, again, one of those, you end up having to educate a lot of people and then they get new jobs, to educate more people all over again. I feel like I'm doing a terrible job of answering all your questions. Like you're asking very direct questions and I'm giving you like evasive answers. It's not on purpose.
I have another one.
Okay, go ahead.
So you are wanting to move to a process where every patient is informed of assistance available. Did I hear that correctly?
So our goal for now is for every patient that's seen by our closed door specialty pharmacy to be screened for financial assistance. That would be a good start. Ultimately, if I can get to where these ladies are, where every patient, regardless of screen, that's great. I really like their idea of having a team of 30 over multiple states. That sounds great to me.
So that was going to be my question. If you have, I don't know if you've looked at that, but what would you envision your team looking like to be able to accomplish? Would you have to double your size?
Anybody? I'm just trying to poach smart people. So is anybody from University of Texas, Houston? So I think they had one that they spoke on about 9 months ago. And I get the numbers wrong. I apologize. I want to say they had 13 farm techs plus maybe another 4 for infusions. So I was like, oh, 17, that would be awesome. But that was just like me salivating at the number they had. It wasn't really based on any. I think it's been difficult for me to get like level of effort or like what's like the unit of service as far as how many, what's the benchmark, right?
Right.
Oh, I should bring my bingo back. Benchmark, was it on there? Okay. I'm struggled with what the benchmark is. A lot of it's been kind of like prove it. And some of the early prove it was like, well, prove it that for every person we're paying, you can save the organization that much money. And it's hard because a lot of times the money you're saving is for the patients, may not necessarily be the organization unless you can show abandonment of cost or write-offs. And those have not always been easy for me because I'm not that smart to figure out or to get access to. So it's been baby steps. Yes, sir.
So it sounds like that the EMRs do stuff but the true scalability still isn't human personnel behind it. There's not much contribution to scalability with the MRs.
So the scalability, you have to have the humans to do it. Scalability is that you have work that you can see and divide up, as opposed to before that, the process was largely you knew a person and you emailed them or you sent them a fax or whatever, and whatever they did, other people couldn't share in the workload. And if they went on a vacation or LOA, no one could track it because it was papers on the desk. So my team would say that what I've given them is actually less efficient than what they had before. So they still are in the mindset of back when I would just do my own work and I was doing it all on paper, I could actually get through more financial assistance cases than what I as a mean old boss have put on them now. They're coming around to it, but they still feel like all things being equal, they could get through more using their paper process than with what I have implemented, right? And I said, I'm okay with that because your paper process, it doesn't work in modernity, right? And a great example is I had someone, they had a death in the family, they had some illness, they had to be away from work. And while they were gone, unless you drove over to where their desk was, dug out all their files, looked at them one at a time, you have no idea where they were in the process. So you're right, it's still the human beings doing the work. I do think this is the right move. I'm not selling it as an efficiency gain. It's really about transparency. You can now look for yourself. You don't have to call and leave a message or email someone and wait for them to respond back. It's all within the EMR, clearly visible. It has metrics that I can measure and see. It has a queue that you can divide up because the Epic work queues are pretty malleable in the ways you can filter them and edit them. But yeah, you're not going to add them. So let's say you have a staff of 10 people. You can't tell your organization, hey, I'll cut 2 FTEs if you let me have this module, because it's not going to give you that kind of efficiency. Was that like an anti-sales pitch? I'm sorry, Epic, if you're in the room.
That's the present. Do you have a opinion about the future already?
Yeah, I do. So I think there's a couple things that are going to change. I honestly believe that real-time benefit investigation and real-time cost transparency are going to get better. We know that on the pharmacy benefit side, it's already a lot better than it was the medical side. In my opinion, where I am in California, not so much. But I really do think if there's enough good minds working on it, there'll be something where it can give an estimate of a patient's out of pocket. It'll give what she was asking for, which is to just have some threshold. Patients may be able to say what the threshold is. Okay, any therapy that's going to cost me more than $450 a month, then I need financial assistance. I'm not going to do it. I think we're going to get there. We're just not there right now.
Thank you.
Yeah, for sure. Anything else?
You have time for one more question.
Oh, no pressure.
I think it does depend on where your hospitals are located and their patient populations. For example, Scripps, like the
beautiful lady up front wants to know if it's
hospitals.
beautiful lady up front wants to know, is it going to depend on the location as far as state and the type of payers you have? And the answer is absolutely. There's definitely some variables based on geography and the white bag and socioeconomics, but also the white bag and some states have been successful in limiting the mandated white bag and others have been less. It's a good final question. All right. Well, we'll be back at 3:30. And like I said, you can call my number. You can email me. I'm happy to respond. If I didn't give you what you need, then I'm happy to work hard.
Thank you.
Thank you.
Thank you.